Okay, good afternoon, everybody, and thank you for joining us for today's Grand Round Seminar at the CUNY School of Public Health. Before we start the seminar, all of you are muted, so if you will have questions, a Q&A session at the end of the seminar. So if you have any questions, please post it on chat, and then I will ask them on your behalf at the end of the seminar. So, so let's go to the seminar itself. So on behalf of the CUNY School of Public Health, the Department of Environmental, Occupational and Geospatial Health Sciences, I'm very pleased today to be with all of you this afternoon and have a chance to introduce our guest speaker, Dr. Robert Wright. Dr. Wright brings together many skills in basic, applied, and clinical disciplines to connect exposomics and phenomics across the lifespan and solve complex problems in environment, human health, disease, and precision medicine. The seminar today will tackle these challenges and these topics. Dr. Wright is the chair of the Environmental Medicine and Public Health at Mount Sinai School of Medicine and director of the NIH-funded Mount Sinai Human Health Exposure Analysis Resource Targeted Lab Hub and Mount Sinai's NIEHS P30 Core Center. He also serves in the Advisory Council for the National Institute of Environmental Health Sciences. He also put together one of the first longitudinal birth cohort studies back in 2007 based in Mexico City to study the developmental origins of health and disease. His funding and scholar record speaks for itself. Finally, as far as long as I know Bob, he's just a people's person, and we're all for a great treat today. Without further ado, please join me in welcoming Bob Wright. Bob, the floor is yours.
Okay, thank you, Elias. So this talk is really meant to bring together medicine and public health. I think of Exposomics as really being representative of public health. And obviously in the field of medicine, all the talk is about precision medicine. And I'm going to try to present the reasons why we may try to integrate these based on an old Flannery O'Connor short story, everything that rises must converge. So the outline of the talk is that I'll describe precision medicine, which is proposed to be the future. I think exposomics is also the future, and I'll talk about what I mean by exposomics. So I'll give a working definition and how we can apply exposomics to understand health and disease. But I think the broader goal of the talk is really to ask the question, can we conduct medicine with a public health lens? So that's a very different way of actually practicing medicine, but I'm going to make the argument that instead of drugs or procedures, we need to think about preventing disease progression. So think about it within a public health framework. So rather than, can we develop a drug to make Parkinson's disease better, or what can we do in a person's environment to slow its progression, or even reverse, in some cases, disease progression. So think of people with the disease as being the same as a vulnerable population. So, and now is the time, I think, to bring together precision medicine and exposomics. So I'll start with exposomics. So exposomics is the study of all of the health relevant environmental factors that we experience across our lifespan. So it's a big task. It includes things like allergens. It includes vector-borne infections. It includes infections themselves, such as COVID and other viruses and bacteria. It would include the microbiome, includes our social environment, our nutritional environment, which is really tied to behavior, our chemical environment, and our physical environment. All these things are part of our exposome. So it's not just chemical. So I come from an environmental health background. My original training was in toxicology, and we really just studied the effects of chemicals on the body. But now I take a much broader approach of what is the environment. And another way to define it is really everything that's not genetics. I don't care for that definition, in part because not everything in our environment really matters that much to our health. So I'm trying to, what we want to do in exposomics is try to sort of interrogate the environment to try to figure out what are the most important aspects of the environment that are affecting our health. So I think of all the health relevant environment across our lifespan. So what is precision medicine? So the National Research Council of the National Academy of Medicine defines it as tailoring medical treatment to patient characteristics. The idea is that through understanding primarily genomics, they can understand susceptibility classifications for disease, and that can categorize people with regards to their prognosis or response to treatment. And if they could do this, it will individualize interventions, maximize benefit, reduce treatment failures, and reduce side effects. What it really is about is it means understanding each patient's individual background and how background influences disease progression and treatment response. It operates in a setting where the probability of illness is 1. That is, preventing the illness no longer matters. Doesn't mean that preventing the progression of the illness doesn't matter. So certainly people who first get diagnosed with diseases like Parkinson's disease or Alzheimer's disease, they get worse over time. So there are things that we can do to try to mitigate the progression of a disease, and some of those things may be environmental. They're not all just treatments and procedures. Unfortunately, for the way that environmental health interacts with precision medicine pretty much ignores environmental health. It's really practiced as pharmacogenetics or pharmacogenomics. And the idea behind pharmacogenomics is that if we understand genetic variation to treatment and disease, we can again target therapy to the most effective drugs, improve efficacy, decrease toxicity, and target behavioral modifications in some cases, improve the counseling and decision-making that patients experience, improve their outcomes and their satisfaction. Well, that's all very good, but it only works if the only source of variation in treatment, prognosis, and disease progression is genetic. If other factors are playing a role, and we are absolutely certain that other factors play a role, pharmacogenomics by itself is not going to work as a precision medicine tool. And yet this is what we see. So if you were to get on the internet and start to Google different precision medicine programs at major universities across the country, you'll basically see variations on a theme where you'll see some figure that represents DNA and discussion about genes causing diseases, and then targeted drugs that are going to be developed because we're going to sequence everybody who has a particular gene, and it's going to be, radically change the way we practice medicine. This has been the argument for about 25 years now since the Human Genome Project was completed, and I can tell you that very little has changed in medicine with respects to genetic causes of diseases in 25 years and how they affect treatment. So it's a promise that has been promised for a long time and hasn't delivered, and I believe it's because we're ignoring the fact that genetics is playing only a minor role in most diseases. So we know that genetics is only one piece of a much bigger puzzle, but for most precision medicine programs, there's no mention of environment. And this is another example of another website in which instead of being oriented vertically, it's oriented horizontally with DNA, drug stratification, and different outcomes. Again, this is another one that's oriented with the same theme vertically, but basically all these websites look pretty identical, and none of them ever mention environment, or almost none of them ever mention environment. But we know environment plays a role. At least complex diseases actually have risk factors that are not genetic. We've known this for a very long time. And so when I say complex diseases, what I'm really talking about are the very common diseases that don't have a single cause. So Mendelian genetic diseases like cystic fibrosis or sickle cell anemia, they have one primary cause. Influenza has one primary cause, a particular virus. Certain bacterial infections obviously have one single cause, but the vast majority of diseases do not have one single cause. Alzheimer's disease does not have a cause. It has many, many causes. So does Parkinson's disease, so does ADHD, so does autism. And the list goes on and on and on, and so do all cancers. So the real drivers of healthcare costs are actually complex diseases, which don't have uniform single causes for their etiology. And we've known this for well over 20 years. In fact, this is an issue of Science from 2002. Excuse me. on the puzzle of complex diseases, and it had an introduction to the special issue that was entitled "It's Not Just the Genes," and there were articles about behavior, nutrition, infections, chemicals, physical environment, culture, society, and stress. And it appeared as though we were on the right path back in 2002, but unfortunately we started going down a genetics genomics path, and I think that took us away from this idea that complex diseases are truly complex, and they're not just complex genetically, they're complex on multiple levels, and most of those levels are actually fit a criteria of being part of the environment. So how did we get here? So, and you'll see some references from different 70s and 80s bands as sprinkled throughout this talk. So David Byrne and the Talking Heads. So as I said, complex diseases are actually the major diseases that are driving healthcare costs. They include ADHD, attention deficit hyperactivity disorder, obesity, asthma, COPD, renal failure, Parkinson's disease, the vast majority of cancers. You know, these are actually what is actually causing our health to get worse over time. Diabetes should also be on that list. Their etiology is a mix of genetic and environmental risk factors I just showed from that issue of Science. They're also becoming more common. Their prevalence and annual incidence is going up and up and up. You know, one of the arguments that counters the idea that autism is a purely genetic disease is that it's becoming more and more common. Genetics cannot operate on a time scale of even 10 or 15 or 20 years. If something is becoming more common over that time scale, it can't be primarily genetic, because genetics requires reproduction in multiple generations to pass. So you cannot explain increases in these diseases based on genetic risk factors. And yet we keep trying to hit this, square peg into a round hole all the time with genetics and the causes of these increases in diseases. Our society is definitely getting sicker, and it's not due to our genes. And in fact, as I said, these genetic main effects cannot explain rising rates, because a lot more time has to pass in 10, 20, or even 30 years. The environmental risk factors for all those complex diseases that I showed are largely unidentified. We know a few, but most of them we don't know, because we haven't invested in trying to understand them. So we have much less research on them. And in fact, I think the language that we use actually in some ways creates barriers. So we tend to think in terms of this old phrase, nature versus nurture. And geneticists in particular like to do studies that are called heritability studies, where they study twins and they parse out the percentage of a disease that they say is genetic and a percentage that is environmental. And there's actually these sort of heritability studies that actually say that autism is actually almost entirely genetic, and yet autism can't possibly get this much more common over such an amount of time if it's purely genetic. And it also ignores the idea that genetics actually confers risk. It's not causation. There is a difference. If you smoke, you're at higher risk for lung cancer, but not everybody who smokes gets lung cancer. So it's a risk factor for lung cancer. It is a cause, but it's not a one-to-one relationship. And genetics is not a one-to-one relationship with disease either. We tend to think that way about environmental factors. We tend to think of genetics as being somehow deterministic when it's not. And so we need to think of both factors as being in conferring risk rather than causation, and that the levels of risk vary for each. In fact, I'm going to take a step back, and I'm going to make the argument that part of the reason why we call a disease a genetic disease or environmental is actually perception. And that perception is a function of the prevalence of the risk factors in a population. So I'm going to make the argument that if a disease is due to a gene-environment interaction, that is, complex diseases always have genetic components and always have environmental components. If the genetic polymorphism is relatively rare or low in prevalence in a population, and the environmental risk factor is common or high in prevalence in the population, that disease will appear to be genetic. And if the converse is true, if the environmental factor is relatively rare or low in prevalence, and the genetic polymorphism is very common or high in prevalence, the disease will give an appearance of being environmental. Now remember, this is a disease that's caused by interactions between genes and environment. This is actually a difficult concept to present in humans, but it's actually very simple to present in chickens. So there actually is a chicken trait called yellow shanks. So yellow shanks are discoloration of their legs with and they get it, this sort of mucousy discharge. It occurs if a chicken has a particular genetic variant and it eats yellow corn as opposed to white corn. And this is actually an example that Ken Rothman, a famous epidemiologist, included in one of his textbooks called Modern Epidemiology. The genetic trait follows an autosomal dominant pattern, meaning you only need one copy of the allele to express the disease. So imagine two farmers, Farmer Jones and Farmer Smith. They live down the road from each other. Farmer Jones has an inbred chicken flock. All of his chickens have the variant for yellow shanks, 100% of them. For that reason, over time, his family learned to feed them only white corn. For generations of Farmer Jones's family, they fed only white corn. One day, the store ran out. He bought yellow corn. All of his chickens got yellow shanks. If you were to ask Farmer Jones, what is the cause of yellow shanks? He would say it's environmental. It comes from eating yellow corn. That's his perception. Farmer Smith, on the other hand, lives down the road. He also has an inbred chicken flock. None of them carry the variant for yellow shanks. Yellow corn's cheaper, so his family has always fed their chickens yellow corn. One day, a chicken gets a new mutation. It gets yellow shanks because it has the mutation and it's eating yellow corn. And Farmer Smith is an amateur geneticist, and he plots a pedigree of all the offspring of that chicken and discovers that half of those chickens get yellow shanks, and the ones who have yellow shanks, half of their progeny get yellow shanks, and the ones that don't get yellow shanks, none of their progeny get it. And so he plots a pedigree, and he figures out that yellow shanks is a genetic disease that follows an autosomal dominant inheritance pattern. So which is it? Is it Farmer Jones's perspective, in which yellow shanks is purely environmental, or is it Farmer Smith's perspective that yellow shanks is purely genetic? It's not hard to imagine that similar things are actually happening in human populations. And there's this artificial divide that we've created over time through our language that actually makes us think that a disease is particularly genetic or particularly environmental, when in fact all diseases are environmental and genetic. So we really can't say if yellow shanks is environmental or genetic. It's contextual. It depends on the prevalence of the genetic variant and the environmental factor in a population. And by the same token, cancer is not purely environmental or genetic. It depends on both the environmental factor that might be causing a mutation, the carcinogen, and whether or not you have a genetic risk factor for being susceptible to that particular carcinogen. And even diseases that we think of as being purely genetic. Phenylketonuria is a disease that's thought to be purely genetic. It's actually one of the newborn screening diseases. If you carry the genetic trait for phenylketonuria, you have two copies of it because it's homozygous recessive, and you are exposed to phenylalanine, which is a very common amino acid that's found in our diet, you'll develop severe developmental delays. However, through newborn testing, you can actually eat very low phenylalanine diets, and you can have a completely normal phenotype by avoiding phenylalanine. So is it really truly genetic, or is it really, truly environmental, or is it a combination of genes and environment? So even diseases that we traditionally think of as being purely genetic almost always have an environmental component that we don't think of. And usually that environmental component is very, very common in the population. And in fact, thinking about heritability, where we parse out whether a disease is particularly, or what percentage of a disease is due to genetics, or what percentage of disease is due to environment, for Farmer Jones, the heritability of chicken shanks or yellow shanks is 0%, and for Farmer Smith, it's 100%. So even heritability is contextual. It depends on the prevalence of the genetic environmental factors in a population, because all genes operate in variable environmental backgrounds. And there's lots and lots of backgrounds. So nutrition is a background. So whether or not you have obesity, whether or not you have deficiencies in vitamins and minerals may affect the way that a disease progresses. People who are pregnant may make their pregnancy can also often make a disease worse. Type 2 diabetes is a very good example. Type 2 diabetes often gets out of control in women who become pregnant because there are these physiologic changes that occur during pregnancy that can actually exacerbate type 2 diabetes, and then it goes away after the baby is born. Geography can play a role. Geography is a background that can affect diseases. So you're more likely to have a stroke if you live at a very, very high altitude. And that's because the oxygen concentration at high altitudes is a little bit lower. And if it's a little bit lower, you tend to make more red blood cells. If you make more red blood cells, your blood's a little more viscous. And so the probability of forming a clot and having a stroke is a little bit higher. And that's been shown that people who live at higher altitudes have slightly higher risk for stroke. Culture plays a role. Culture is about behaviors and diet, and those things can actually play a very big role in whether or not you're going to get a disease or what your response is to a treatment. And then environment itself is not a single issue. So, very few children with lead poisoning are only exposed to lead poisoning. They're exposed to many other chemicals. We're all exposed to combinations of different chemicals or mixtures. And we need to start thinking about those mixtures rather than one chemical at a time. And then probably the most important background, I'm going to argue, is having a disease, because disease states change metabolism and increase the risk of exposure to multiple drugs. So people who have a disease are taking drugs, and you're more likely to have a drug-drug interaction, and you're also likely to have a drug environment interaction. So there are lots of ways in which environment can play a role in the progression of a person's disease. So here's some examples. So this is the classic example that you will see on 99% of precision medicine websites. So a 53-year-old woman develops a deep venous thrombosis, which is actually a major clot in their thigh, on a trans-Pacific flight. So one of the risk factors is being relatively immobile for a long period of time. So if you're sitting in coach for 12 hours, you're not moving your leg much, and you're much more likely to get a blood clot, which is what leads to a DVT. So after she lands, she sees her doctor, and she gets given a blood thinner called warfarin, excuse me, and she gets a GI bleed. So in this particular case, she had a genetic variant that actually made her a slow metabolizer of warfarin. And because she got a standard dose, it was too big for her. And she ended up having a bleed because she doesn't metabolize warfarin the same way that other people do because of genetic variant. So in this case, genomics would play a role in precision medicine and improving her healthcare because she had a genetic variant. But for that case, that's a great example, but there are many, many other situations in which genetics would not play a role. So here's an example from a patient I once took care of. A 17-year-old child with autism has notable increases in head banging and anger outbursts. So we tend to think of autism as a genetic disease. So I can tell you a genetic scan found nothing that would explain this. Also, he's 17 years old, and all of a sudden he has a change in his behavior. He has new head banging and anger outbursts. Well, it turned out he had lead poisoning. And it's a little weird for a 17-year-old to get lead poisoning, except 17-year-olds with autism. So people with autism have what's called pica, the non-food substances. He turned out to be eating newspaper. Newspaper ink has a little bit of lead in it, and he was eating enough newspaper where he was actually lead poisoning himself. Paradoxically, his 3-year-old brother, who did not have autism, did not have lead poisoning either. So in a general situation, a 3-year-old is far more likely to get lead poisoning than a 17-year-old. And that's because 3-year-olds and toddlers tend to have a lot of hand-to-mouth activity. They get dust on their fingers, and if there's lead in the environment, they'll ingest that dust by putting their fingers in their mouth. 17-year-olds don't typically do that, but this was a 17-year-old with autism. And so the background that he had, his autism, actually made him at risk for lead poisoning. We were able to treat him, and his head banging and anger outbursts improved dramatically once he was chelated. So here's another example. So a 14-year-old who has gastroesophageal reflux, he's constantly burping up fluids, and a history of depression. He breaks his arm, and he's treated with morphine for a fracture, and he gets respiratory failure. He had a genome scan before they gave him morphine that showed no functional variants in genes that could affect morphine metabolism. Well, GE reflux might be treated with over-counter medications like Tagamet or ranitidine, which is also called Zantac, and these actually can inhibit the P450 enzymes that metabolize morphine, and Paxil can do the same. So what was happening in this case is he had a drug environment or drug interactions, which could have been picked up with a exposomic scan of the medications he was taking, but because this wasn't part of precision medicine, wasn't picked up. And a genome scan would not actually have picked up anything because it wasn't due to anything in his genetics. It had to do with his diet potentially and his medications. For example, grapefruit juice is kind of famous for being a P450 inhibitor as well. So maybe he was taking grapefruit juice as well as over-the-counter Tagamet and had a history of depression, taking Paxone. All these things interfered with his ability to metabolize morphine, and that's why he got respiratory failure. But again, a genome scan would not have picked that up. So if we're going to really practice precision medicine, we can't just isolate genetics and think that we're actually going to change much. We have to include the environment. We have to include what I call exposomics, all aspects of the environment, because I think the most important background in precision medicine is the disease itself and the treatment for that disease. And if we understand the way that environment interacts with the disease and the potential treatment for the disease, we'll be able to prescribe more precise medical interventions, many of which come from the public health field of just avoiding certain environmental exposures or promoting nutrition. So, but to start to get physicians to think this way, we have to do the studies that that physicians need in order to treat patients. So right now, we're not really doing that. There are very few examples of environmental studies that take place in people with a disease. So, and there's a reason for that, because the public health perspective and the medical perspective are very, very different. So this is the medical perspective. So as a doctor, I want to be able to diagnose the patient. So I want the research that's done to help me diagnose the patients. So sometimes exposomics and epidemiology can help. So risk factors are a kind of weighted variable. I'm 59 years old. If I had chest pain and presented to an emergency room, particularly if I was a smoker, you would probably assume, based on the research that's been done, that I'm at very high risk for having a heart attack, and you would assume that the cause of my chest pain was a heart attack. So help me treat the patient. Well, there it breaks down a little bit. As a physician, the fact that I'm a 59-year-old man who smoked has nothing to do with my treatment. It's not going to change anything. It's not going to change the medications I'm going to get. It's not going to change whether I'm going to get surgery or catheterization. It doesn't help at all. In fact, I may even ignore the results of such studies because it doesn't help me treat patients. I'm no longer trying to prevent the disease from occurring in this scenario. I'm trying to treat the disease. So the risk factors that caused it don't really help very much. So in order for us to bring environment into medicine, we have to ask different questions, because there are no right answers to the wrong questions. So what are the roadblocks to bringing environment into medicine? Well, medicine operates at the individual level. Public health operates at the population level. When people present to a doctor, something's going on. The doctor may not know what it is. They may not have diagnosed them correctly, but there is a problem that exists. In public health, people start out healthy and they may develop a problem later on, but at the moment that they typically get enrolled in a study, they actually don't have the disease yet. And then it's all about treatment and whether or not there's side effects and what treatment will get the best outcome. So in public health, as I said, instead of individual level, it operates at the population level. We think about risk factors. If you're exposed, will you get sick? If you smoke, will you get lung cancer? Yes, you may get lung cancer, but not everybody will. So it's really a probability. It's not a one-to-one relationship. I had my father-in-law was a 2 to 3 pack a day smoker for about 60 years and never got a heart disease or lung cancer before he passed away. So it doesn't always fit one-to-one, although definitely there's a higher risk of getting lung cancer or heart disease if you smoke. That's absolutely clear, but it's not a one-to-one relationship, because it's really about, in public health, about prevention at the population level. That's why it doesn't work as well at the individual level, because it's just harder to get people to change their behavior if they're not actually sick. Public health thinks about susceptible populations. Children, pregnant women, the elderly tend to be the classic susceptible populations. But it's a different perspective. And part of it is just time. So medicine gets involved after the person is sick. public health gets involved before the person is sick, because public health is trying to prevent that person from getting sick, which is a very noble goal. But there are already millions of people who have a disease. So what can public health teach medicine about how to help them? Because outside of primary care, medicine is very little interested in why you are sick. They want to understand how to treat the disease. But perhaps there are environmental factors that can actually help treat the disease. Then it's all about the research that needs to be done. So in public health, as I said, the research tends to be before a disease is present. So on this graph, to the right, a disease or phenotype is present, and to the left, it's not. The x-axis is time, and then the different types of study designs that we do. We can do a prospective cohort study where we follow a group of healthy people over time, and some of them develop the disease and some of them do not, and we see which risk factors had a higher probability of predicting the disease. Or we can do what's called a case control study, where we take a group of people with a disease and a control group, and we see which risk factors they have, and we try to go back in time to see whether or not that risk factor preceded the onset of the disease. And in genetics, they typically do some variation of case control family-based association, because your DNA sequence never changes across your lifespan. So you almost never see a cohort study in genetics, because it's not very efficient, because your DNA sequence never changes. So geneticists tend to think only in terms of case control or family-based association studies. Physicians tend to think in terms of randomized clinical trials, because they're trying to see whether a particular treatment is better than a no treatment or better than a different treatment, or they're doing a clinical observation study where they take a group of patients with a disease to try to see whether or not, in many cases, a genetic risk factor predicts a higher or faster progression of the disease. But medicine tends to think in terms of what to do after the disease occurs, and public health tends to think of what to do before to prevent the disease from ever occurring. So it's two different types of mindsets. Public health thinks of causation risk factors, medicine thinks of diagnosis and treatment. So can we link these? And if we're going to, we have to start studying what happens after someone gets a disease. And in public health, we very, very rarely do that. So what I'm arguing for is that patients with a disease should be thought of as a vulnerable population. And one of my arguments for this is, I'm not against prevention. We still have to do prevention, but there are millions of people with type 2 diabetes and obesity. There are millions of people with Alzheimer's disease. We have to start thinking about what we can do for them. And there are environmental modifications that can help them. So why now? So there have really been exponential advances in exposure science in the last 10 years. Exposomics is really about measuring as much of the environment as you can. There are what are called untargeted chemical assays. So our lab at Mount Sinai can do these. These can measure tens of thousands of chemicals in a sample of blood or urine. We can also measure targeted chemical panels. We can measure phthalates. We can measure PFAS, the forever chemicals that are in the news a lot. We can measure most of the chemicals that happened in that East Palestine train derailment. And we can do that, hundreds and hundreds of chemicals now at a time. So we're getting much better at the chemistry. At the same time, because of big data, we're able to measure a lot of other things. I know there's folks in the geography department that probably do satellite remote sensing to estimate exposure to air pollution, temperature, green space, light at night, among other different types of variables. Public databases can give information about the geospatial distribution of diseases such as COVID, but also things like SES, historical records that show how redlining has occurred and the effects of racism on health. All these things are things that we can do now with public database mining that we couldn't do 10 years ago. We can mine electronic medical records. And then almost everybody has either a smartwatch or at least a cell phone. So that all of us are wearing wearable devices, or many of us are wearing wearable devices that actually give us information about our physiology, our activity, our heart rate, all kinds of things. Even things like EKG strips can now be actually derived from wearable devices. And the big data computational infrastructure to analyze all this data simultaneously now exists. That didn't exist 10 to 15 years ago. So the time to do exposomics really is now. There have been so many advances. What we really need is some larger umbrella to bring it all together, because all of these fields are somewhat disparate. The expertise that is needed to do satellite remote sensing is very different than the expertise needed to do untargeted chemical assays. And so the field is a bit disparate because of that, because different groups of people are working in different aspects of the exposome. So, as I said, public health is interested in studying vulnerable populations, but has largely ignored the role of environment in response to treatment and the effects of environment on people with the disease, on the disease severity or its progression. As I said, the largest vulnerable population to environment may actually be people with a chronic disease, and we need to study their environments. So I'm going to bring some ideas together about ways we can use some of the exposomic methods that I just described in studies. So untargeted chemical assays, this is what's called a chromatogram. So these are features of a chromatogram. So this is a mass spec device. So you process urine, you enter it into the instrument. It tells you based on molecular weight and the charge, a distribution of chromatograms. And these are what are called features, and the features represent individual chemicals. So untargeted assays may aid in diagnostics. So if you have people with a disease and people without a disease, maybe there will be different signals that are seen in people with a disease or not. So a great example might be, say, eating disorders like bulimia. People with bulimia are going to have different kinds of metabolites in their bloodstream or in their urine that actually may be unique enough so that you can use it to actually diagnose a disease. And in fact, what if we focused only on cases? Maybe if we had patients with a particular disease and we measured the untargeted signals over time, we could see whether or not there's a correlation with their signal patterns and the progression of the disease or its severity. So we need to actually start looking at these cases of different metabolites and chemicals and see whether or not these signals can actually form what are sometimes called exposomic risk factors. So people talk about polygenic risk factors. We have how many genetic variants do you have and how does that increase your risk for a disease? Why not think about exposomic risk factors and how many clusters of different metabolites do you have and how does that correlate with your risk for disease progression? So other ways that we can operationalize the exposome in precision medicine using untargeted assays. So we need to run untargeted assays in cohorts of patients longitudinally so that we can predict the risk of complications. So maybe on randomized controlled trials, maybe we can start getting some of these assays longitudinally from each visit, and we can actually start to predict the response to treatment. Maybe the people with a particular set of signals at the start of a trial are more likely to actually respond to the treatment than people who won't. So we can actually identify clusters of people who may actually benefit from the treatment and those who may not. So, and then there's wearable devices. So also the Internet of Things. So a lot of the devices in our lives are connected to the internet, phone apps, cars, appliances, sensors, etc. These devices exchange data with the internet and with other connected devices. We can download GPS data and physiologic data directly. And there's even a very low-tech exposome wearable device. So it's actually a silicone bracelet. There's actually a company called My Exposome that you can actually Google. You can order the bracelet. They'll send it to you. You wear it for a week. You send it back, and they'll do an assay on the bracelet and tell you what environmental chemicals you were exposed to in the last week. So obviously, most of this is going to be stuff that fell on it from the air, but also things that you may have excreted in your sweat or from your clothing that may be touching it. So it's not quantitative, but it is a pretty decent qualitative estimate of what you've been exposed to while you were wearing it. So this is becoming more and more popular, and it's now its own company. So we don't know a lot about these wearable devices in patients with diseases. I think there is some work being done right now. But we need to start tracking people who have, say, Parkinson's and Alzheimer's disease for their physical activity. Maybe an Apple Watch can actually help tell us whether somebody with Alzheimer's disease is actually starting to progress to the point where they're not able to take care of themselves based on data and patterns in that data in the Apple Watch. So maybe it actually tells us something about chemotherapy as well. Patients who are less active may be having more severe reactions to chemotherapy. So using these wearable devices in patients may actually aid diagnosis and treatment and understand progression. We need to start thinking about other ways that the environment affects patients. So maybe air pollution, which we know is a risk factor for heart disease, actually may exacerbate patient symptoms and complications after a patient's had coronary artery bypass. One of my favorite recent studies was a study out of University of Washington a few years ago, which showed that patients who had had a lung transplant had a higher 5-year mortality rate if they lived in an area of higher air pollution than an area of lower air pollution. So there are definitely effects of air pollution on our lungs and on our heart. I think that's been pretty well established. But what we really haven't studied is, what about people who have diseases of their lungs and their heart? What is the air pollution doing to them? And are there things that we can advise them on, such as HEPA filters, or even, quite frankly, moving to an area where there's less air pollution, if you can afford it, that may actually prolong their lives? And there's lots going on in what I'll call the external exposome in geomedicine. We can measure air pollution and climate, exposure to green space. We can measure temperatures, traffic patterns and noise, access to healthy foods in the built environment. And even, like, one of my favorite studies is one of our faculty who actually, you can actually get GPS coordinates off Twitter, who actually published a study on the geospatial distribution of mean tweets in the Boston metropolitan area. So there's lots that can be done. Almost everything can be mapped. And in fact, I think even those untargeted assays that I were describing with the chromatograms, if you know somebody's address, you can map it. So I think we can start to map all kinds of aspects of the exposome: the social exposome, the infectious exposome, the chemical exposome, as well as more traditional measures like weather variables and air pollution, noise and light. All those things can be mapped. And if we start to overlay those maps, we can start to see the patterns of how the exposome interrelates with health. So how might we operationalize exposomics in medicine? For those of you who like the Ramones, wearable devices. So one day, I envision a day where you'll take a wearable device that connected to your cell phone that tells you where you are. Google and Apple probably know where you are right now. They can even tell whether you're indoors based on the signal strength of the internet or the cellular signal. And you'll get information, highly accurate information, if it's overlaid with maps of air pollution, temperature, and other physiologic data that links that physiologic data to weather and air pollution, as well as activity. And that can be downloaded by your doctor into a mainframe computer that might analyze it using machine learning to understand what risks you are at going forward. If we have your address history, we can actually link these maps back in time to where you used to live. If we have your occupational history, we can probably estimate different types of exposures that are probably more likely to occur with certain occupations and job activities. So simple questionnaires, job matrices may actually help us understand the exposomics long-term if this were to become part of your standard medical record. So one day you'll give your cell phone at the front desk when you walk in the doctor's office, and the data will be, with your permission, obviously you have given informed consent, the data will be downloaded so that we can estimate your exposure to all these different environmental variables. You'll probably take an untargeted screen of your blood or urine, and that what chemicals you're exposed to will be linked to your genome scan that all the different precision medicine systems want to use, and they'll integrate that data with the environment and the genomics to get a risk score for how likely you are for a disease to progress, or how likely you are to develop a disease, and maybe even some simple recommendations for what you can do to reduce your risk. So I think that is the goal one day for exposomics in precision medicine. And right now, there's a lot that can be done. If you think about applying environmental health or exposomics to diseases, and this is just off the top of my head, phthalates are thought to be a risk factor for lung disease, and they're thought to be a risk factor for diabetes. Well, people with cystic fibrosis and Mendelian genetic disease have higher rates of diabetes and pancreatitis, and they also have lung disease. So what are phthalates doing to them? So we think that their disease is almost purely due to the genetic trait, and I'm not disputing that, but phthalate exposure on top of that might be actually making their disease phenotype more severe. And that's an area that needs to be studied. And we think that environmental obesogens like PFAS, so forever chemicals, are a cause of diabetes. Well, type 2 diabetes is an extremely common disease in the United States. There's tens of millions of people with type 2 diabetes. They're all exposed to PFAS. Is it making their diabetes worse? Is it actually predicting whether or not they need a higher or lower dose of insulin? That's a study that hasn't been done. That's a study that probably should be done. If we think that if these environmental exposures actually cause diabetes, we need to ask the question, well, what's it doing to a patient who already has diabetes? And then we think a lot about metals that are neurotoxic, such as lead or mercury or arsenic. Well, regardless of whether you think they're a cause of Alzheimer's disease, and you don't even have to think they're a cause of Alzheimer's disease, but if somebody has Alzheimer's disease and they're exposed to lead, what's it doing to their Alzheimer's disease? And that's another area of research that needs to be done. Maybe the air quality in surgical ICUs is actually leading to a slightly increased mortality and morbidity rate. So we're not routinely measuring that. And untargeted chemical assays might actually, as I said earlier, be a risk factor for eating disorders such as anorexia or bulimia. So unlike traditional public health causation research, if you flip the question and say, well, rather than thinking about whether or not that cause diabetes and say, what is it doing to people with diabetes? If you just do that simple exercise in your head, the field is so open that almost all the diseases are low-hanging fruit. So I'm getting close to the end. Exposomics, I think I've shown, is a very complicated field. It requires the integration of multiple types of data, some of which are going to be questionnaires. I think questionnaires will always have a role, particularly for social stressors or job occupation. We can't go back in time to measure everything, so we're going to have to just deal with the fact that everybody's memory is imperfect, so we might get imperfect data, but it doesn't mean that it's not valuable. We'll be using GIS-based models, satellite remote sensing, actually also mining public databases. I think photographs are going to be used more and more often in research. I think if we took a picture of that cabinet underneath your sink so we could see all your cleaning products, we could tell a lot about the types of VOCs that are actually likely be in the environment of your apartment or your house. And then obviously we're still going to do biomarkers in blood or urine. There's going to be a role for mobile devices like smartphones and accelerometers to actually tell us what's going on, both where you are, but also what you're exposed to in your local environment, and what your physiologic reaction is to that. And then this data, I think, can be linked with other types of omics. When people think about genomics or epigenomics or proteomics, I think all those things can be linked together. I think the missing piece of the puzzle, though, is this exposomic piece that's actually at the top of this graph. So I think in the future, exposomics in precision medicine are going to enable better diagnostic tests, so we can identify subpopulations that have different prognoses of disease. We can understand the relationship between a patient's chemical, nutritional, physical, and social environment and their prognosis. And we can also identify optimal treatments based on someone's exposome so that we can reduce variability to treatment response by modifying their environment, reduce side effects, and increase compliance. So that precision medicine programs, instead of being purely genetic, will look like this, where people are stratified based not just on their genome, but on different characteristics of their environment that actually, I think, are going to be more likely to predict treatment response and failures. So instead of looking at medicine from a purely medical perspective, look at medicine from a public health perspective and think of patients as vulnerable populations. And then one of the programs that I'm part of is called HERE, the Human Health Exposure Analysis Resource. We will do a wide range of assays that can be used in different precision medicine initiatives or traditional epidemiologic and public health studies on targeted chemical assays, metabolomics, which actually come along with the untargeted assays. Untargeted assays include both the metabolome and exogenous chemicals. One of our faculty, Manish Arora, is a dentist and a chemist, and he specializes in assays that can actually measure chemicals in teeth. Teeth grow like trees, so you can actually go back in time based on the ring pattern in a tooth and actually measure rings that were laid down at different life stages and what chemicals got laid into those rings is something you can do, very analogous to what happens in geology with trees. We can measure heavy metals, and all that data could be actually linked to different omic data. So, although I think the most important omic, obviously, and perhaps I'm a bit biased, is the exposome, which I think is going to complete the complex disease puzzle by asking the right questions that benefit patients. So, and that is my last slide. So thank you all.
Thank you very much. I mean, one of the problems with the online is we cannot really congratulate for this excellent presentation. So I have, there's a couple of questions for you. Paolo, can you unmute the dean? Okay.
Thank you, Professor
Please.
Wright. This is Ayman Al-Mohandes. I'm the dean of the school, and really enjoyed your presentation very much. Having spent a very large part of my career in medicine and then moving now to public health, I'm intrigued by the theory that you presented in its breadth, and have to ask you perhaps a naive question. I'll give you two diseases that, like Farmer Smith, I presumed were genetic diseases. Let us say Duchenne muscle dystrophy or sickle cell disease as two known genetic diseases. Is it because I'm limited in my knowledge, or is it because we have not discovered the environmental component that allows this disease to manifest, or can you help me?
Well, I've taken care of a lot of patients with sickle cell, so I'll focus on that one because I'm less familiar with muscular dystrophy other than it's X-linked recessive, and I don't know what the gene is actually involved in. But for sickle cell, yeah, if you think about the paradigm of whether disease appears genetic or environmental depends on the prevalence of the genetic factor and environmental factor. So the genetic factor is relatively rare, and the environmental factor is oxygen, which is very, very common. And so sickle cell anemia appears to be genetic because the environmental factor is pretty much unavoidable. Same thing is true for cystic fibrosis, which is sodium potassium pump. It's completely impossible to avoid sodium potassium, so it's going to come across as a purely genetic disease. Sickle cell is really interesting from an environmental perspective because there are things you can do in your environment that can help. Obviously, high altitudes can sometimes trigger sickle cell crisis. Patients who have infections may get crises, and there's all kinds of environmental factors that can cause inflammation. So certainly any chemical that was a risk factor for pulmonary toxicity is probably something someone with sickle cell needs to avoid. And so there may be ways that in the future we might screen patients with sickle cell anemia for what's in their local environment to try to help them avoid things that might be toxic to the lungs. So obviously, when I was young and I was a dishwasher in a restaurant, I foolishly mixed ammonium and bleach, and I made chloramine gas, and I was coughing for about a month. If I had sickle cell, that would be something that probably could have killed me. And so there are probably household items that people with sickle cell may want to avoid. So that I see that as something that may be part of medical practice. In fact, I think one day there'll be the equivalent of genetic counseling for exposomics. So there'll be people who learn how to counsel based on exposomic measurements in patients, how they can actually improve their health. So hopefully that will one day be an actual profession.
So to complete the cycle, my understanding in the sickle cell situation is you're really talking about the disease symptomatizing rather than the disease in its very purest pathology in the construct of the hemoglobin or the appearance of the red blood cell. You're talking about the symptomatology of the disease being triggered by environmental circumstances.
Yeah, the variant will sickle and low oxygen will make it worse. So
Right, yeah.
oxygen is the environmental factor for the particular gene variant. And then all the other things like crises or strokes, they're downstream complications of the disease.
Got it. Thank you.
Great question.
Okay. Andrew, do you want to pose the question, or can you unmute Dr. Marocco?
Hey, thanks so much, Elias. Dr. Wright, thanks for the talk. It was really interesting. My question is not so technical. It's more practical, I guess. So some of the studies that you're suggesting more people should do require a really broad range of skills and backgrounds and data sets, so forth, so on. So like in your experience, what's the best way to actually convene those groups? Since it's rare, you're gonna have one person that knows all these things. What do you think is like an efficient and effective way to convene this group of very different people that often speak functionally different languages?
Yeah, well, the folks on this call have the skills that are very, very different than the medical folks. So very few physicians understand how to measure the environment. Probably the majority of them are probably not even aware that air pollution is a cause of heart attacks. It's just not taught in medical school. So some of it is bringing people together. The physicians will not have the epidemiology skills. They will not have the environmental health skills, but they will have the patients and they'll understand the biology of the patients. And so the public health professionals and the exposure scientists, I mean, to me, it's like a perfect team because everybody brings something complementary to the table. The key, quite honestly, is, and I'm trying to say this in the nicest possible way because, you know, genetics is the 800-pound gorilla. And so right now, geneticists are not interested in the environment. I have sensed a change in the last few years. I think there's starting to be some frustration, probably from Congress, that precision medicine hasn't done anything yet. And so I think from my read is that NIH is starting to look for other things other than genomics because they know that genomics by itself isn't going to change anything. So I do think in the next few years, the potential for those sorts of partnerships to develop is going to be greater and greater. And people with public health, particularly people with exposure science skills, are going to be able to form those partnerships much more easily, I would argue, in the next 5 to 10 years, because there's going to be a big demand for them. So I think it's coming. Exposure science is going to become much, much bigger because it makes sense. There's just, if you look at, you know, almost every example of genomic causes of almost any complex disease you can name, whether even autism or Alzheimer's or asthma or cancers, it explains at most about 25 to 30% of the disease. The vast majority is actually due to environment. And I think that's starting to be accepted finally. So I think it's going to change. And I think your skill set is going to be complementary to the physicians. As a physician, I can tell you that the average physician's understanding of environmental health is next to nothing. They just have to start to be convinced that it's important. I mean, I think that's going to come in the next few years.
Before I give it, I have one question on the chat. David Mile is asking whether the rise on the disease we've seen, it is because we are more aware about the diseases right now and is diagnosed more frequently than it used to be?
That's the argument that the geneticists make about autism, because it's been pointed out to them that it's impossible for genetics to explain a rise in autism. I think it used to be something like 1 in 1,500 children, and now I think the most recent is like 1 in 40 children. It's just grown exponentially. I think it's gotten to the point where people are starting to question whether it's just there. In the early days, there was probably more screening and probably more detection. I think it's gotten to the point where it's a little hard to believe that that percentage of children should have autism, that something hasn't changed. Also, for other diseases such as obesity and asthma, those diseases are clearly becoming more common. There's no question about them, and those are complex diseases. Alzheimer's disease is clearly becoming more common, although we're getting older as a population. But it's pretty clear that for the vast majority of diseases, they're just more common.
Okay. Dr. Soliman, Paulo? Can you unmute?
Hi, Gad. You would need to unmute your mic.
Yeah, Dr. Soliman and then Dr. Yusuf.
Can you hear me now?
Yes.
All right. Well, thank you so much for that presentation. It was very informative. You focused more on the external exposome. I work on the internal exposome. I usually do untargeted metabolomics. I started first by targeted metabolomics a while ago, a long time ago, because people were accusing with the fishing expedition. So now I'm doing the untargeted metabolomics, high resolution untargeted metabolomics in cells. So I look at adipocyte cells or beta cells, and I differentiate between different metabolomes. And then I look using the predictive pathways in statistical software to try to find the relation between the metabolite versus the pathways versus the proteins. Do you envision this type of strategy would work on the long run with comparing disease state versus non-disease state, and instead of just using predictive models, using also experimental genomics data, plugging it in the model to get more onto the signaling and the pathways and the affected genes?
Well, I think untargeted metabolomics and untargeted chemical assays have a clear role. I do think we have to recognize, you talked about fishing expedition, that it's discovery research when you do an untargeted assay, because you don't have an a priori hypothesis about what you're going to find. So, you're more likely to make a type 2 error, and that's okay, because that's where replication comes in. So we have to replicate what we find when we do discovery research, whether it's from the external exposome. You can do discovery research by measuring 100 different external environmental factors, or you can do discovery research using untargeted assays. And we just have to recognize the role of chance. So we're trying to discover what's going on and then replicate it. Genetics got into trouble 20 years ago when they were doing GWAS and publishing their GWAS discovery analysis as if it was something real, when it is technically a fishing. I hate to use the term fishing expedition, but that is the term that gets used, and it has to be replicated first. And we don't want to fall into that trap. We have to replicate our findings too. If we start with a discovery approach, which I would argue untargeted chemical assays are, we do have to consider a multi-stage design where we also replicate.
Yeah. So I'm not totally blind in terms of discovery, because I have a hypothesis about a pathway, nutrient sensing pathway, that is mTOR pathway. So what I do, I just use the prototype rapamycin, which only blocks part of the functions of mTOR. And then I use another drug which inhibits both mTOR complexes, and I compare between them and the control, with the hypothesis that mTOR controls proliferation that will lead, that's related to cancer, but it also controls, it's an anabolic kinase, so it affects diabetes. And from that perspective, I'm comparing whether this pathway is inhibited versus this pathway is intact by using the drugs to inhibit it. So it's not just looking at the metabolomics from an unfishing expedition. I'm just having a hypothesis about the specific role
Sure.
of kinase.
Sure. Yeah, I mean, I'm aware of people that we've worked with that have an a priori of a component of the screen, but still analyze the
Mhm.
whole screen. So
Yeah.
one component can be, if it has an a priori, that's perfectly, that's a hypothesis test, but the other things are not. So we just have to be cognizant of that. So.
Mhm. Thank you.
Pedro?
Thank you very much. Such a fascinating presentation. I wonder, this is a very selfish question, but it's related to my field of research, which is hepatitis C among people who inject drugs. And we often wonder two aspects of hepatitis C. One is the exposure. And of course, among people who use drugs, the environment where the drugs are being injected and the nutrition, the nutrition of the person over time might have an effect on the actual exposure. And perhaps equally important on the natural clearance. So I wonder, under your exposomic framework, what are your thoughts about that interplay between environment, virus, natural clearance, and nutrition over time?
Sure. Well, as a toxicologist, when I think of, liver toxicity, hepatitis C, being a hepatic virus, I would think of chemicals that affect the liver, manganese and cadmium that bioaccumulate. The one that's in the news all the time is PFAS that bioaccumulates in the liver and is associated with a high risk of fatty liver disease. So I would wonder what those chemicals are actually doing in patients with hepatitis C. Maybe it's increasing the progression of their disease. And from a nutritional perspective, I mean, obviously, I'm sure you're thinking about alcohol, but there are other aspects of the diet that actually, like iron, for example, gets stored in the liver that may actually play a role in modifying the progression of the disease. So, yeah, I think the sort of mental game I kind of played when I said this hypothesis should be tested, this hypothesis should be tested. If I was thinking of hepatitis, I think of certain liver toxins, and instead of thinking of them as the cause of the liver disease, obviously it's not the cause. In most cases, it's the hepatitis C, but it may still be making the hepatitis C worse. If you have hepatitis C and you're exposed to excess cadmium or you're exposed to excess PFAS. So measuring those chemicals in patients with hepatitis C may actually give some insights as to why some patients are worse than other patients.
Thank you.
I think that concludes our session for today. I would like again to thank Bob Wright for joining us today. It was a very informative presentation. And Mount Sinai is just down the road, so there is plenty of opportunities. I know some faculty in the school already work with you guys, and as well as part of the ASRC initiative. So again, thank you very much, and thank you everybody for attending the event and making time today.
Thank you, guys. Thank you all.
Appreciate it.